Thank you very much. Okay, the second questionnaire, by the way, that you've been given is for the lecture that's coming now. So you just need to fill out the first one. You won't get 2 questionnaires every single time. You'll only get 1. It's only a page. It makes a hell of a difference. So thank you very much for completing it. Okay, I have been given the most exciting topic to present to you. No, not really. It is really, really boring, actually. Will it be entertaining? Maybe. But is it important? Definitely. When you are interpreting results, the most important thing is to remember the patient, okay? So don't just look at the numbers, remember the context as well, because the same result for one person will mean a completely different thing for someone else. And you don't need to know every single antibody test. You really don't. You just need to know the basics really well, okay? You won't get caught out when you're a junior doctor about complex stuff. No one's going to say to you, oh, you're not good at your job because you don't know something really, really complicated. You will not get away with not knowing something fundamental, though. So the key really is to learn the basics thoroughly. Okay. When I first started working, on my 3rd day, I had to chase results. And what that basically means is you sit in front of a computer and write down all the test results that you've requested for patients on your ward onto sticky labels, and then you stick them in the patient's notes and sign them. That is a pretty mundane job, actually. And I think almost all the F1s did that at the beginning. And when I came across a patient's result which looked a bit odd, I can't even remember what the result was now, but I turned to my registrar and said, oh Steve, so-and-so's results are, really weird. Can you have a look at them, please? And he did, and then he looked at me and he said, okay, so what are you going to do about it? And I kind of went, what? When you're a medical student, you're expected to know stuff. When you actually start working, you're expected to act on things. So when you get handed somebody's INR, you actually have to dose their warfarin and prescribe it without anybody looking over your shoulder. So there is a process which we have to remember. We don't just do the mechanics of writing the stickers out and sticking them and then not looking at them. You actually have to do something, okay? So and that works with anything, okay? If the nurse asks you to come and see a patient because his temperature is now 39 degrees, you actually have to do something. You don't just go and take a look at it. And if it's something that you can't handle, you have to alert someone more senior to you. So it's all about acting now and not just learning stuff. And the process is, you look at the signs and symptoms, you decide what investigation you want to do, you interpret the results, and then you think, okay, what am I going to do now? Am I going to treat? Am I going to order more stuff? And don't bother learning any of the reference ranges. You will be given them in the exams. But when you're on placement, it's quite useful to know the important ones, like your potassium and your sodium ranges, and you'll come to know them the more and more you look at tests without even realising. So what I'm going to talk about is FBC, hematinics, USNEs, LFTs, and inflammatory markers. What I'm not going to talk about is all this stuff. AVGs, peak flow, X-rays, that will all be covered in uroscopy stations I think next week you're having one on respiratory, so they'll talk to you about interpreting that. ECGs, there's a lecture next Tuesday. Histology, that's stuff like looking at, Crohn's and ulcerative colitis and things like that. They'll get talked to you about in lectures. Microbiology, you'll get some infectious disease teaching. CSF, they'll cover neurology, and autoantibodies is pretty much in everything, from hepatobiliary disease to hematology. So you'll cover that in lots of different areas. Right, there's lots of stuff in the full blood count, okay? I think if you're a hematologist, it's really important to know what they all are. If you're you need to know these ones. You need to know how to interpret these really well. If you don't know why someone's neutrophil count is whatever, no one's going to tell you off for that, but you need to know these, okay? But just as a kind of general rule, neutrophils, if they're raised, it's normally bacterial. Lymphocytes, normally viral. And eosinophils, they're the allergic, parasitic type things, okay? I think lymphocytes and eosinophils are also raised when you've got malignancy as well. But there are so many other things that I wouldn't even bother with that. White cells. The white cell count is those lymphocytes, neutrophils, and eosinophils all added up together. It's that simple. Okay, so if one of them are raised, then your white cell count is going to be raised. And it's raised when you've got either an infectious process going on or an inflammatory process going on. Now you might be like, well, that's kind of the same thing, isn't it? Not always. In vasculitis, for example, that's an inflammatory process, it's not infectious. So you can get a raised white cell count with that. In surgery, you can get a raised white cell count if someone's just had an EVAR. But that's all you need to know, really. It is very non-specific, so it kind of falls under the remit of your inflammatory markers. Other things to remember about the white cell count. Swinging white cells, along with swinging pyrexia, always think abscess. Rule that out. Okay? What is a very high white cell count? Well, if it is above the normal range, do not ignore it. Okay? There's obviously something going on. If it's more than 20, it's really, really bad. You need to tell somebody. And the last patient I had with a white cell count of more than 20 was a guy on my vascular ward who had a massive ulcer on his leg. And his white cells were slowly creeping up every single day. And then suddenly they were 26. And I looked at the screen and I was just like, oh dear, this is not good. So I spoke to the microbiologist, I spoke to my consultant, I spoke to the dermatologist, and every single time I said that my patient had a white cell count of 26, they all suddenly started to listen very, very in a very interested way. So white cells, don't ignore them. And remember to do something about it. It might be put another blood card out for tomorrow, start some antibiotics, and investigate the source. Okay? You may need an ultrasound of the abdomen, you may need a chest x-ray, but you need to do something. I'm just going to talk about PCV very quickly now because it's so simple. If it's raised, it's polycythemia. You've got different types of polycythemia, as you all know, your true and false, and that leads off into lots of different types even from there. So I'm not going to go into that because it will be covered in your hematology lecture, okay, in a lot more detail. But if it's raised, it's polycythemia. If it's low, think dilutional. So your hemoglobin, you never just look at that in isolation. There are three main things you need to look at together. Hemoglobin, your mean cell volume, also known as mean corpuscular volume, and your red cell distribution width. So if you've got a low hemoglobin, the next thing you do is you look at your mean cell volume. Okay? The mean cell volume will tell you whether the anemia is normocytic, microcytic, or macrocytic. It is not uncommon to have both an iron deficiency, which is microcytic, and a B12 deficiency, which is macrocytic. So if you've got something microcytic and macrocytic, you could have a normocytic MCV. But actually you've got two different things going on there. And that's when you look at your red cell distribution width, because that will give you the average size of your red cells. And if it's raised, that means your red cells have a wider variety in their width, okay? So it will tell you that you've got small red cells in your iron deficiency and big red cells in your B12 deficiency. So the red cell width will be raised. Is that clear? Yeah? Following? Everything okay? If you want to ask me questions as I go, just put your hand up, that's fine. So, You don't need, I mean, this is not an exhaustive list for macrocytic anemia, but the ones in bold are things you need to know, like the back of your hand. So if someone said macrocytic anemia to you, you need to be like, yeah, well, iron deficiency anemia, thalassemia, sideroblastic anemia. Like, it just needs to be like that. Okay? So microcytic, low iron, low MCV, normocytic, iron, and a normal MCV, and macrocytic is low iron and a raised MCV. And the important ones are the ones in bold. I'm not going to talk to you about what thalassemias are. You know, you've got your beta major, your alpha, beta, major, minor. We will have covered them in pediatrics last year anyway, but that will be discussed in your hematology there. Okay? So once you've discovered that your patient has an anemia, and you've got an inkling of what type of anemia it might be, you're thinking about what's actually going on here. So you request some hematinics. And the hematinics are your iron, B12 and folate, that's it. You need to know a little bit about how iron and B12 is actually absorbed to understand the rest of this. So, iron is absorbed from the small bowel, and it is absorbed as Fe2+. It gets absorbed into the plasma where it's carried to bone marrow, to the red blood cells, by a protein called transferrin, and it joins the red blood cells and becomes heme, or if there's any excess, it gets stored as ferritin and hemosiderin, primarily in the liver. Okay, that's nothing new, I'm sure you all knew that already. B12 is slightly different. It gets absorbed again in the small bowel, and it needs intrinsic factor to cross over into the plasma. Okay, an intrinsic factor is secreted by the gastric parietal cells in the stomach. Folate is really straightforward, it's just absorbed from small bowel. So if you suspect that someone's got iron deficiency anemia, but they don't have a low iron on their hematinics, which can happen, why? Why might someone have an iron deficiency anemia but have normal iron?
Didn't they do an iron tablet?
Yes, that is one possibility.
They've got a low blood volume.
They've got low blood volume. No. Oh, what was that?
Acute blood loss?
Acute blood loss. No, not really.
If you have reticulocytes.
Okay, this is you guys are getting really seriously into the pathology. Iron also acts as an acute phase reactant. Yeah. So if someone's got a chest infection or a malignancy or something, their ferritin will go up even though they actually have iron deficiency anemia. Does that make sense? Yeah. So what we do in those situations is, well, in the past we used to do this thing called iron studies, and that looks at total iron binding capacity, ferritin, and transferrin receptors. Okay? The total iron binding capacity, which you may not have come across before, is basically measures how hard the body is trying to bind to the iron. So we draw some blood, we send it to the lab, and the lab measures the maximum amount of iron that sample of blood can hold. Okay? And the soluble transferrin receptors are basically receptors that go hunt out iron and found on red blood cells. So, if you've got iron deficiency, you'll have a normal iron, raised TIBC, because your body is trying really, really hard to get as much iron as possible, so your TIBC will go up. Yeah? You'll have a low ferritin because your iron stores will be low, and you'll have raised transferrin receptors because you'll want to be catching as much iron, or your red cells will want to be catching as much iron as possible, so they'll be raised. In chronic disease, it gets a bit more complicated. Because ferritin acts as an acute phase reactant, that will actually be up, so it gives you a false picture. You're like, well, I think this patient has some iron deficiency, but the ferritin's raised. Well, that's when you can look at the soluble transferrin receptors. That will tell you the truth, because if there was a real iron deficiency anemia, your body would be producing a lot of these to try and catch as much iron as possible. And in iron overload, so in like hemochromatosis, for example, you get raised iron, low TIBC, raised ferritin, your iron stores will be up, and you'll have low receptor molecules. Is that clear? Yeah? Okay. B12 deficiency is primarily caused by either pernicious anemia or bacterial overgrowth, so problems with absorption of B12. Very, very rarely is it actually caused by some sort of dietary deficiency, okay, like with poor B12 intake or something like that. It's mainly a problem associated with absorption. So in the past, again, we used to do what we call the Schilling's test, and that happens in 2 stages. So you give an oral, and I'm telling you about this because you could get an MCQ on it, okay? And also on placement, you could get asked about this. And you do need to know it, even though in practice we don't really use it that much anymore. So it's in 2 stages. The first stage is you get an oral dose of B12 and an IM injection of B12. In a normal person, or in a healthy person rather, at least 10% of that will be excreted in a 24-hour urine collection. And then after, but obviously in someone with pernicious anemia, that will be reduced, because it will just get excreted in the stool. Does that make sense? It hasn't been absorbed from the bowel. The second stage then is you give some oral B12 and some oral intrinsic factor at the same time. And it's the intrinsic factor that people in pernicious anemia don't have. So this time when you give that and your injection, your urine level of B12 should be more than 10%. Yeah? So the other reason why you can have B12 deficiency is because of bacterial overgrowth. That will prevent absorption as well. So there are 2 ways you can do that. You can either give them do the first step of the Schilling test and then trial a week of antibiotics, and then repeat the first stage of the Schilling test, and then if you've got a normal B12 urine level, then you will know, okay, this is probably because there was some bacteria in the gut and now it's been treated and it's disappeared. So the patient's back to normal. A much easier way to do it, though, is the hydrogen breath test. So you give an oral load of carbon dioxide, which gets metabolized by this bacteria and releases loads of hydrogen, and then that gets picked up on the breath test. Okay, but actually, in reality, what we tend to do is anti-gastric parietal cell antibodies and anti-intrinsic factor antibodies. It's much easier. You don't need to collect urine, and you don't need to give them antibiotics. But if you do get someone with a low B12 on their hematinics, and you get that as a result, before you actually start replacing that B12, you do have to check the antibodies, just in case you're just in case they do actually have pernicious anemia as an underlying thing. Does this make sense? Yeah? Okay, we're going to talk about some cases now, and these are cases which I've actually seen. Just looking at these results, what do you see? Like, with no history at all. If you're going to say something, say it loud and proud.
Raised white cell count?
Raised white cell count. That could mean infection. What else can you see?
Macrocytic anemia.
Mixed picture.
Mixed picture anemia. Yeah.
Mixed picture anemia, but macrocytic anemia as well, yeah, because obviously raised MCV, yeah. What else can you see? Is that it?
Low
Low B12. What do you think of the ferritin and the folate?
Borderline.
Yeah, but normal range. Yeah, you agree on that? Okay, so I'm going to give you some history now, okay? You're chasing results as an F1 doctor, this actually happened to me, for an 82-year-old lady called Doris, her name wasn't Doris, presented with a cough, green sputum, and you can hear crackles at the right base. Now what do you think is going on? What does she have? A pneumonia, that's fine. What are you going to do about it? Chest x-ray, I heard, yeah. Blood cultures, good. Sputum sample. Some repeat bloods. Yeah. Curve score, yeah. What would you do to treat?
Depends on the curve score.
Depends on the colour. I really like that. Everyone's really awake. Okay. So depends on the curve score. What does? Okay. So essentially, you're going to give them some antibiotics depending on the curve score, right? And what the course of antibiotics will vary depending on the curve score. Okay. So you've given this patient some antibiotics. What else are you going to do? Are you going to treat their obvious anemia? Are you going to give them, how are you going to treat that? Are you going to transfuse them or just, what are you going to do? Find out cause of their anemia. Is that what someone said? Yeah, okay. How are you going to do that?
History.
Okay, take a history.
You might need an OGD.
Yes, okay. Do you think this 82-year-old lady, you jump in there with an OGD now?
No.
She's a bit poorly. It's not one of the first things we do. But, okay, so we think she's got a low B12, right?
Yeah.
So what would you do if you suspected someone's got low B12?
Antibodies.
Antibodies, excellent. And then after you check the antibodies, what are you going to do? You'll replace her B12, right? You're not just going to leave it. So you'll prescribe her some B12 replacement, hydroxycobalamin injections. Okay. What do we think of her iron? Is it okay? Are we happy with that?
Well, to see whether it was a trend, so whether she'd been like on 30 a few days ago and it's dropping, or whether the level's normal.
You don't have access to that information.
If she's got an infection, it should be raised, shouldn't
It might be raised because she's got an infection.
So therefore it should be actually low.
Yes, and it is on the borderline low side, isn't it? So she could actually be iron deficient as well, which is in keeping with our mixed picture. How about that? So what would you do to investigate the iron? Yeah, so you would do iron studies, or you do that ZPP that I talked about, which is a lot easier and what we actually do in practice. Yeah, and then you'd know whether she was actually iron deficient, and you'd replace her. You give her some replacement iron. Are we not going to transfuse this patient?
Depends how well she is.
You said no. Why?
Not less than 8, but I should probably look at the clinical picture.
Would you like to know some information about her?
Yeah.
What would you like to know?
How well is she? Is she?
How unwell is
Does
she?
she look clinically anemic? Is she pale or does she have?
She's not pale.
She rather
Is she exhausted?
No.
Is she tired all the time?
No.
Probably calmer.
You're calm.
I know I am calmer about the situation.
Oh, you're calm. Fair enough. No, you're probably right. So we wouldn't transfuse her because she's not she doesn't have clinical symptoms, does she, of the anemia? She's just got this infection going on. And actually, infection can make you drop your HB in reality. And it can do that. So her HB might be lower now than it normally is anyway. Okay? Right. Second case, same results. 52-year-old man with long-standing epigastric pain, lethargy and headache. What would you do with him? Did someone say endoscopy again? What, straight away? Do an amylase, I like it. So more blood tests, yeah. What do we think is happening with this guy? Epigastric pain, lethargy. Potential bleed, yes. Okay. Now, looking at that, would you transfuse the patient? Did you say yes?
It's lower because it's a man.
It's lower because it's a man,
It's
yes.
lower in relation to him. And also, you haven't found the cause of his bleed, so he's probably still bleeding.
Really good reasoning, yes. So you would transfuse him. Excellent. You can do pretty much anything in medicine as long as you can justify yourself. So yeah, that is very, very good reasoning. A lot of the time, you just need to forget what you know and just use a bit of common sense and reasoning, okay? So yeah, you transfuse this guy, but you wouldn't have transfused the other lady. Right, let's move on. Urine and electrolytes. 4 components: potassium, sodium, urea, your creatinine, and EGFR. I'm not going to talk a lot about the EGFR because we don't use it that much. It's mainly just for staging, and also certain drugs don't work or become toxic if your EGFR goes below 30 or 15, depending on the drug. So hyponatremia is the most complicated one, so we'll get that out of the way. It's anything less than 135 millimoles per litre, and it depends entirely on the clinical picture. So you need to know, does my patient look dry and dehydrated? Is my patient actually okay, looks quite well? Or is my patient really swollen? Like, does he have loads of peripheral pitting edema? Does he have fluid in his lungs? That kind of thing. And the way I tend to remember it is hypovolemic patients, just think of the failures. Liver, heart, kidney failure. Particularly, for example, nephrotic syndrome. Yeah? You can get low sodium with that and swelling in your legs. The normovolemic patients are the most difficult ones to diagnose. What we tend to do is serum and plasma osmolalities, and we fluid restrict them because you can get SIADH, which I'm not going to go into detail about because you have an endocrine lecture coming up. But what you tend to do then in those situations is, if there's a cause, because SIDH can actually be caused by so many things. You can get it after a head injury, you can get it when you're poorly, you can get it from lung cancer, okay? And if they've got any of those things, you might be thinking, oh yeah, there's a link there. So you fluid restrict them because they're drinking too much, and you also do the blood tests. And in hypovolemic patients, the most common thing is, well, they've just become acutely dry. They've become really dry because they're vomiting loads, or they've lost a lot of blood or fluid somehow. And diuretics are really nasty for this kind of thing, particularly furosemide. And hypernatremia, on the other end, is just these 4 things, which are so obvious. Obviously, poor water intake, you think, surely that's dehydration, so wouldn't the sodium be low? But actually, your body compensates by secreting lots of ADH, and poor water intake is a chronic thing. It's probably happened over a bit more time than you suddenly vomiting loads, for example. So your body has had time to adjust, and actually the sodium level goes up instead. And IV saline. And don't fall into the trap of just IV fluids. These patients have loads of IV fluids. They could have had like dextrose. But it's IV saline that you need to watch out for. And drugs containing sodium. Loads of antibiotics, for example, contain sodium. And hypokalemia and hypokalemia, these are really important emergency situations that you need to know about. Again, diuretics, vomiting, diarrhea, stoners, Cons and Cushing's. Cons is basically the opposite of Addison's. Hypokalemia, AKI. Hypokalemia is something you really need to know how to treat. Spironolactone is a potassium-sparing diuretic, so it causes a hyperkalemia instead of a hypo. DKA, Addison's, and rhabdomyolysis. Just out of curiosity, does anybody know what test we normally monitor for rhabdomyolysis? Yeah, excellent. Okay, urea is really raised. You don't need to know much about urea. It's raised when you're dehydrated, when you've got renal failure, and also when you've got an isolated, if you've just got a randomly raised urea and nothing else, you have to think of a GI bleed. You have to exclude that. And how high does it need to be? It doesn't actually need to be that high. It could be like 10, but it could be much higher. And creatinine is raised when you've got poor kidney function. So, cases. You have a 78-year-old man admitted with shortness of breath, lying flat, swollen legs, and he has a past medical history of diabetes and high blood pressure. He's on aspirin, lisinopril, dendrochlorothiazide, and simvastatin. So, firstly, what do we think about the sodium? That's low, isn't it? We said high. Okay. Why do we think, and looking at our patient, is he normo, hypo, hyper?
Sounds hypo.
White jump.
Something. Because it comes lying flat, it sounds like and he's got heart failure. He's hypovolemic.
He's hypovolemic, excellent. Okay, so we've got a hypovolemic hyponatremia, which is probably related to his heart failure. Fine. What about his medications? So I'll just tell you them again: aspirin, lisinopril, dendrochlorothiazide, and simvastatin. When someone really confident shout out something. He's on diuretics. Good. So that's going to basically flush out his. It's going to flush out his everything. His potassium and his sodium. But his potassium is actually high. Is there anything else that he's taking? Lisinopril actually causes a hyponatremia. There are a number of drugs that you need to know about that cause hyponatremia. When you're on placement, keep an eye out for them. Lisinopril is one of them. And in regards to the diuretics, yes, they do cause a hyponatremia as well, but they tend to cause a hypokalemia at the same time. Not always, but this guy's got a high potassium. So what do we think of the rest of his biochemistry? Why is it so low? He has a history of diabetes. Is it CKD though? Is it CKD? It's AKI, isn't it? It's AKI because he's got hyperkalemia as well as a raised urea and creatinine. If it was CKD, he would have a raised urea and creatinine chronically, and probably not a raised potassium, because that's something that is usually treated with dialysis and other drugs, yeah, to sort out the potassium. But if you what is creatinine? Yeah, it should be high. That should be really, really high. In fact, it's that reference here which is wrong. Okay, so his EGFR is 10. Are there any drugs that you'd like to stop? Yeah. So you'd stop your lisinopril and? And you'd stop your simvastatin. Simvastatin, basically it doesn't work and it's bad for you if your EGFR is less than 30. So you keep an eye out for that one, because everyone does. Okay, LFTs. We all know what these are. Where do they come from? This is important because it will help you actually interpret them. Forget about the AST. You don't actually see them very much on the LFTs when you order them in the hospital. The only ones that you see are ALPOS, ALT, and bilirubin. If you want GGT, you have to request that specifically. So your ALPOS is really non-specific. That's why, and it is related to bone as well, which is why it's in the bone profile. Your ALT is released from hepatocytes when they get damaged. Your GGT is released from so many things like brain, kidney, everything, but it is also released from your bile duct and gallbladder. And that's the ones you need to remember. Bilirubin, you all know about bilirubin. But it is a good indicator of how poorly or how bad the liver is damaged. Okay, so you get hepatic and obstructive. Hepatic's when you've got a raised ALT, obviously, because that's when the hepatocytes release the ALT when they're damaged. And obstructive is when you get a raised ALPOS and GGT. And you can also